Thank you very much for a great introduction. A great pleasure. I enjoyed very much this meeting with a lot of discussion. I focus on two main issues today, which are a bit relatively new. One is mechanical power, and the second one is the role of transpulmonary pressure, so that I think we can discuss all together. No conflict of interest. These are the main mechanisms for ventilator-induced lung injury, which is high pressure, high tidal volume, or resting volume at end expiration and cyclic reopening. And we know that there are different factors that may induce ventilator-induced lung injury, which are tidal volume, plateau pressure, driving pressure of the respiratory system of the lung, the positive end expiratory pressure. But other factors have been less considered, like respiratory rate, which is associated with different inspiratory flow, and all of them may promote ventilator-induced lung injury. And this is why the concept of energy delivered by the ventilator to the lung, or the power, mechanical power delivered from the ventilator to the lung, has been raised in these last years. So we are moving from the concept of barotrauma to volutrauma to atelectrauma to ergo trauma. What is mechanical power in joule per minute is the rate at which work, so the energy in joule, is done. And so we are talking about the mechanical ventilation and dissipation of energy when inspiratory energy is higher than expiratory energy. We have heat or inflammation in the lung, and this may be associated with ventilator-induced lung injury. So what is the energy that we are delivering with the ventilator? This is a graph showing the volume and the pressure. This is the volume that you gain with the PEEP, and we don't consider here. And this is the volume of the tidal volume during breath. This is the level of PEEP that we are applying. So this rectangular area is the energy given by the ventilator by the PEEP in a static condition. We don't consider this triangle because we don't know in clinical practice how much is the volume that you get with the PEEP above the residual volume. But anyway, this is a minimal amount of energy that you are giving to the lung. Then this is the static energy. This is the plateau pressure. This is the PEEP, so this is the driving pressure. And this triangle is the energy that you are delivering during the tidal breath. And the difference here between plateau pressure and peak, so this trapezoid here, is the resistive energy that you are delivering to the lung and especially to peripheral airways. So if you know the pressure and you know the tidal volume, independently from the level of PEEP, you can measure the energy delivered by the ventilator. So the area is the rectangular trapezoid, and as you know from the high school, the area is the major base, so the peak plus major base, so the peak pressure, because it's the peak pressure and zip here, even if you have PEEP here, so this is basal, major, plus the minor basal, which is A, which is the PEEP plus the resistive component, times tidal volume, which is the height, divided 2. So big base, at least we say in Italy, the trapezoid area is the big base plus the minor base times the height, which is tidal volume, divided 2. Okay? You can follow, and if you develop this equation, you have 2 times peak minus driving pressure, tidal volume divided 2, which can be rewritten as 2 times peak pressure minus driving pressure divided 2 tidal volume, which again can be written easily, peak pressure minus driving pressure divided 2 times tidal volume. So this is the energy, tidal volume, times the peak minus driving pressure divided 2, times 0.098, which is a constant to convert from centimeter of water and milliliter to joule, okay? Is a constant for So this is the factor of energy, tidal volume in liter, peak and driving pressure in centimeter of water. Okay? This is the energy delivered to the lung for each breath in controlled mechanical ventilation, in volume control. In pressure control, the formula is a bit different, but the calculation is very similar. So, now we make some example. We have a patient with a tidal volume of 0.5 liters, so 500, peak pressure 30, driving pressure 15, so you can make the calculation, means that every breath has 1 joule per breath, okay? Why this number? Because 500 is more or less protective tidal volume, 30 is the peak pressure, maximum, no? Usually is equivalent to 26, 27 plateau pressure, and this is the maximum driving pressure. So at the maximum protective ventilation, 1 breath is 1 joule. If you want to calculate the power, you have to multiply the energy per breath times the number of breaths. So if 15 breaths, it will be equivalent to 16 times 6 joule per minute. If it is 30 breaths, it will be 33.3. So you see that the respiratory rate play a major role in the amount of power that you are giving to the lung. Then, now we look at what happens when we are protectively ventilating a lung with low tidal volume, respiratory rate 24, relatively low PEEP at 10, plateau pressure very protective, 25, and driving pressure around 15, okay, which is the maximum. If you calculate, this is equivalent to 16 times 4 joule per minute, okay? Now we look what happens when we increase the tidal volume. When we increase the tidal volume, and I reduced here the respiratory rate at 12 in order to keep the minute ventilation constant, the same PEEP level, but the plateau pressure increases because we are increasing the tidal volume, and the driving pressure is increases. And look at that. Now, mechanical power, even if respiratory rate is lower, is almost double. So that's why we have not to ventilate our patient with high tidal volume. And the second message is high driving pressure is bad when it's associated with an increasing tidal volume. First message today for me. High driving pressure is associated with mortality, but this does not mean that if we reduce driving pressure, the patients go better. I will show you it. This just means that if we increase tidal volume and driving pressure, of course, increases, this is bad for the energy that we are empowered, that we are delivering to the lung. Then we give you another example, that lower plateau pressure is much more important than to reduce the driving pressure if you increase the plateau pressure. Look at that. Now you have a case with low PEEP, relatively low PEEP 11, plateau pressure 25, very high driving pressure, which is within the limit, at 0.5, and 20 respiratory rate. You have 17.6. Now, we increase the PEEP, I just put 22, we can put 20, so the people who loves to have very high PEEP, okay? And we increase not too much the plateau pressure, within the limit at 30, and we markedly decrease the driving pressure, and we are happy. That's correct? We are happy because we put the PEEP high and driving pressure decreased. Compliance improved, so the patient is better. I don't know. Because if you keep the same respiratory rate, look, just the increase in peak pressure, which is plateau pressure, even if you reduce markedly the driving pressure, you have much more energy and much more power to the lung. So that means that if you reduce the driving pressure by increasing the PEEP, but you increase even not too much the plateau pressure or the peak pressure, this may be associated with a major increase in the mechanical power and energy. So this means that if you apply the PEEP and you improve the compliance, this can be worse for the patient. Can be worse for the patient. I don't believe anymore, and I will show you also clinical data, that if you set the PEEP according to the best driving pressure, this is the best for the patient. And this data, theoretical data, absolutely explain why is the case. It's good if it is driving pressure is high because you are delivering high tidal volume. That's why we have to reduce tidal volume. So driving pressure is very important to target the tidal volume. If at 6 or 7 milliliters per kilogram ideal body weight, driving pressure is higher than 15, we should reduce the tidal volume. But this is not the same if you reduce the driving pressure by optimizing the PEEP. This, I think, is a very important concept. So be aware of the plateau pressure, which play a major role in the energy that you are giving. Keep the plateau pressure as low as possible. Lower driving pressure impacts mechanical power and energy when associated with a reduced tidal volume and not when you are setting the best PEEP. And this is a study in animals when we delivered energy and power, the minimal power, so at low tidal volume and lower respiratory rate as possible. Then at this minimal mechanical power, we increase the tidal volume. So the concept is, if the theory is that only mechanical power per se is associated with lung injury, we should expect the same lung injury for the same mechanical power. That's right. We are delivering the minimal mechanical power, but with different tidal volumes. And of course, here we are reducing the respiratory rate. And look at that, we had a progressive increase in lung injury. So this means that even at lowest mechanical power, you should deliver the lowest mechanical power with the lowest tidal volume as possible and the lowest driving power as possible. If you deliver the lowest mechanical power with the higher driving pressure or higher tidal volume, you don't get the positive effects. So again, the lowest tidal volume and the lowest driving pressure and the lowest plateau pressure are the best combination in our condition. And we did another study with lower power or higher power with low tidal volume or high tidal volume. You see here, if you deliver the low tidal volume but you increase the respiratory rate here, you have more damage. So you have to minimize the respiratory rate in order to achieve, for example, a pH higher than 7.25, if you can. But if you deliver high tidal volume, with a low power, you see you have an increase in the damage, as I show you in the other study. Of course, if you combine high tidal volume and high respiratory rate, you have the worst effects. But again, tidal volume is crucial, but is not the only factor, because you see here, if you need to increase too much the respiratory rate, you increase the power, and even low tidal volume may damage the lung. There are some data, these are not randomized data, but are clinical data. This is the first study we performed on more than 8,000 patients, mainly non-RDS patients. We calculated mechanical power according to the formula that I showed you. And you see, we found that when mechanical power was higher than 17, there was an association, again, this is not randomized, just an association with mortality. And this, interestingly, this is what was caused by higher tidal volume and driving pressure. And even when higher mechanical power here was due to low tidal volume and low driving pressure, but likely high respiratory rate, we have an increase in mortality. So it's not enough to reduce tidal volume and driving pressure. This should be associated with the minimal respiratory rate as acceptable for the patient. And interestingly, we had almost 20% of patients who developed RDS, and in this patient, mechanical power was associated independently on mortality, even in RDS, and without the presence of neuromuscular blockade. So in non-RDS, we found that the mechanical power threshold in terms of risk of death was around 70 to 20 joules per minute. Another very recent study from China, a big population of patients with RDS. You see here, they normalize mechanical power with the predicted body weight, and I transfer here with joule per minute. And this is the standardized for predicted body weight. And you see in the mild, they did not find relationship, but they found a constant relationship with severe or moderate RDS. And you see when you have more than 17 or 20, more and more, higher is the risk. So a little bit different compared to our study. Our study showed that even in mild or non-RDS patients, we had an increase in mortality when the threshold were higher than 17. But in severe and moderate, seems to be even stronger the relation between mechanical power and mortality. And these are very nice data from Quintel and Gattinoni. Look at this. This is the lifeguards. It's very recently published on Blue Journal. These are patients undergoing ECMO, and they look at mechanical ventilation. And you see here in the non-ECMO and during ECMO. In this big study, this is not randomized, but they found that during ECMO, there was a major reduction in the power of mechanical ventilation. This is, I transferred these variables in joule per minute. You see that before ECMO was around 27. During ECMO was around 10 joule per minute. And this was the Eolia that was discussed this morning. Before the study, it was above or around 27 joule per minute. During ECMO, just around 10 joule per minute. And the same in another very recent study published observational. So all this study on ECMO, mechanical power was very high, higher than 25. And was a major reduction in mechanical power when ECMO was delivered. So, in general, I believe that we can consider this variable in the future. Of course, we need more knowledge. But in OR, we should keep mechanical power below 12 joule per minute. In mild ERDS, below 17 joule per minute. In moderate RDS, below 22 joule per minute. In severe RDS, below 27 joule per minute. And perhaps this might be a very interesting parameter to start to think about ECMO. If joule per minute are more than 27, probably we have to start to think about ECMO. So this is the first message that I wanted to give you today. Of course, these are not randomized data, but it's something new and can give you an overall picture when you are at the bedside on the different components of possible factors inducing ventilator-induced lung injury. So this is what is my view, our view on how we treat RDS in patients with PO2 higher than 150. These patients, we always try, if possible, non-invasive ventilation. But we intubate immediately these patients if tidal volume in positive pressure is higher than 10 milliliters per kilogram predicted body weight. For us, tidal volume, higher tidal volume, and increasing respiratory rate are the two main factors to intubate patients early. And then, if they are intubated, we start with assisted ventilation immediately with a PIP level between 5 to 10 centimeters of water. In patients with PO2 ratio less than 150, of course, we start with low tidal volume and we adapt tidal volume even lower if driving pressure has to be maintained below 13. So if with 6, driving pressure is above 15, we further reduce tidal volume. That's why driving pressure is important. Not to set PIP, but to optimize tidal volume. This is my view, which is different from what is commonly believed. Minimal respiratory rate to maintain a pH higher than 7.25 or 7.2, I would say. Low plateau pressure as much as we can, so this means that we have to reduce the PIP, we will discuss later. Low driving pressure according to the optimization of tidal volume. The minimal PIP between 11 to 15 according to the minimal saturation, so not the minimal driving pressure, but we will be for further discussion. And recruit maneuver stepwise only as a rescue. Mechanical power, as I show you below, 27 in more severe RDS, and if higher, we start to think about ECMO. Prone position always in these patients, that's why it was in the slide, for at least 12 hours a day. Neuromuscular blockade agents, not mandatory. Very often in prone position we need them with increased sedation, but we try to reduce as much as possible, especially from the last study. And ECMO, if 6 hours with PO2 ratio less than 80, mechanical power above 27, and or pH below 7.2, 2.5, or PCO2 higher than 60. So this is how we treat RDS. So now we can and we can discuss after this. I think I was asked to give a very clinical concept. I hope that I give you our team interpretation of mechanical ventilation. Very easy. So now we go to another very exciting topic, which is transpulmonary pressure. Do we need, don't we need? So why we don't measure transpulmonary pressure? This is from Bellani's study. Esophageal pressure is measured in less than 1% of mechanically ventilated patients. These are the facts. So we are very disappointed. Why? Because measuring and interpreting esophageal and transpulmonary pressure is very complicated. And I will discuss a little bit about that. So, two big reviews, a nice review that I suggest you. This is the first we published in 2014, and then there is another one by Maury published in 2016. So for those of you who want to have more information, these are, I think, two landmark reviews on this topic. While esophageal pressure and transpulmonary may be useful to partition rescue mechanics, to assess lung recruitability or guide the recruitment maneuver, to optimize the level of PEEP and tidal volume inspiratory pressure in passive condition, and we will discuss just these three items, and in spontaneous ventilation to detect better the reverse triggering or transpulmonary pressure. We will discuss a little bit on that, work of breathing and patient ventilator synchrony. We don't discuss in detail these issues today. So to measure esophageal pressure, we need some device with a balloon or without a balloon to measure the pressure in the esophagus, and the esophagus is here, which is near to the pleura, so it's supposed to measure something related to the pleural pressure. But from this slide, you see that we are measuring at this level of the lung. So the question is, what are we really measuring? We have the heart above, we have the lung above that, and we are measuring at this level, which can be different here or different here. So this is important to exactly understand in supine position. In the early studies, esophageal pressure was measured upright. From Mili Cemini, the physiologist, was a completely different issue. There are normal subjects spontaneously breathing in upright position. Now we have diseased patients in mechanical ventilation, in supine position, and the lung is completely different from the normal one. So we're talking about another world. We cannot transfer physiology from one side to another. Some technical consideration. Patients should stay in the semi-recumbent position, never measure that in supine position. You have to retrieve, how to manage the feeding tube is another issue, because you have two catheters if you have an additional catheter. We don't know. When they experimental by Milich and at the McKinsey in Montreal, completely different situation. Only the esophageal balloon, not nasogastric esophageal balloon and then some the Nava catheter, or other catheters in the esophagus. We have to insert a dedicated catheter. Usually we put at the lower third of the esophagus, but I showed you that this is not only the problem. The problem is which pressure from the sternum to the vertebra. The lower third is from the apex to the diaphragm, but then we have to sternum to the vertebra. And we are used to inflate 0.5 to milliliter. It depends on the catheter. So now a very nice study from Francesco Moioli in Italy. Here you have different catheters, no? Always with a balloon. And here you see the compliance of the catheter, and this is the level performed at different level of pressure. So lower level of PEEP or higher level of PEEP, okay? First of all, you see that the amount of volume at which you have a flat curve, so it means that the pressure does not change with the inflation volume of the balloon. It changes dramatically from 1 to 2 milliliter for each catheter. So each catheter has a different compliance of the balloon, which is a problem, okay? Because you get completely different measurements. And then you have an effect of this curve, calibration curve, according to the PEEP, so the external PEEP that you are applying. So not easy. And this is a nice study from Francesco Moioli They did that, and inspiration and expiration, this is the pressure that they measure according to different volume. You see how it's changing the esophageal pressure when you inflate inflate the balloon. Can you imagine? If you inflate this, you have 5. If you inflate this, you have 10. And then we want to measure the absolute transpulmonary pressure. What we are talking about. It's better to measure, to put the PEEP or the pressure on the ventilator. At this, the airway pressure is the airway pressure. Here we are talking about numbers at the lottery, okay? They suggest to go to the best volume here. And in fact, they found that if you go to the best, the difference between the difference in esophageal pressure and airway pressure, it should be around 1, no? At the occlusion pressure. Is the best, but you know, this means that for each balloon you have to calibrate in each patient. Very difficult, very difficult. Can you imagine a large randomized trial with that? Or in the night, or I mean in my busy ICU with 35 beds and trauma coming, cardiac arrest, intra-abdominal balloon, consultants, and then we measure the calibration of the esophageal pressure of the balloon for one time, because we don't know what happens after 1 hour. Now there is a new catheter, for example, developed, which is very nice, I like. Is a nutritional catheter with an esophageal and gastric balloon. So you need at least only one catheter. This is not so large, so it means that the patient has not to be, have drainage from the stomach, so only for nutrition. It's something that, for example, we use in the post-operative in some condition, but anyway, it's more expensive than a conventional nasogastric tube. So, I mean, some problems also from this point of view, but this is a new technological advice. This is a study we did with Marcelo De Abreu some years ago, and we compared the air-filled with liquid-filled with the balloon catheter. And look at that, with the balloon catheter, how much is the heart influence on the signal, while much less with the air-filled or liquid-filled. So, and the data were very similar. So what I mean is that perhaps the balloon is not the best way, but while the air or liquid-filled simple catheter might be easier, much less expensive, and less influenced by the cardiac oscillation. So you see, also from technological point of view, you can have a lot of developments. We believe that only the balloon catheter is the standard. Then we can measure the height of the patient times 0.2, and then usually this is to calculate the length at which we have to put the catheter on the third, the best cardiac oscillation. I show you that it depends on the device, and we should perform the occlusion test. So you see here what we showed, that you have the patient has to be put the catheter in the gastric here, stomach, if you are able to do. Then the balloons here, you see the esophageal pressure. When you move up the catheter, then it depends. If you have double balloon, of course, it's different. And then at a certain point, you see here that you have a tracing that seems to be quite acceptable, and especially when in line with the gastric. So you see here when you have increase in pressure, decrease in the esophageal pressure, inspiratory effort, and then increase in the stomach. Of course, when the patient is not having expiratory activity, because the patient's expiratory activity is even more complicated. This is the occlusion test. During you occlude the airways, the patient is spontaneously breathing, and in blue you have the esophageal pressure, in red is the airway pressure, and if you assume that the balloon is correctly positioned at the occlusion, you have no change in volume. That's correct? So the transpulmonary pressure should not change. Do you follow me? You are occluded, no change in volume, no change in transpulmonary pressure. So it means that the swings in esophageal pressure should be exactly the same of the swings in the airway pressure, or at least within 10%. If you are in controlled mechanical ventilation, what you have to do, you have to occlude the airways, attend the expiration, and to gently push on the thorax, you increase the pressure in the airways here. You are at the occlusion here. This is the conventional breath. You occlude the airways, you push gently on the thorax, and then you see the artificial increase in the airways and the artificial increase in the esophageal pressure. And again, they should be very similar. These are the two methods to get information if the balloon is correctly positioned or not. But again, it's for that moment. It's for research, because it's after 2 hours, the patient is moving, or the nurses, or whatever, you don't know anymore what's going on, okay? The balloon has to be recalibrated, the maneuver has to be redone, very complicated. And you see here, this is the changes in esophageal pressure and airway pressure in spontaneous breathing at the occlusion or during inspiratory effort at the compression of the chest during occlusion. And you see this is the curve that you would expect between changes in esophageal pressure and airway pressure, which should be more or less the same within 10%. This is the occlusion method. Is it clear? Now, what we did was, even many years ago, was to measure the pleural pressure within the thorax with the wafers, and now we did in Dresden with thoracotomy, so very, very sophisticated technique as compared to what we did with John Marini years ago in Oxford. We have opened the chest wall at that time. And these are the data in controlled mechanical ventilation. You see here, this is the pleural pressure. This is the esophageal pressure. This is inspiratory, this is expiratory. This is the dependent lung, this is non-dependent lung. First of all, look at the non-dependent lung. Expiratory. You see here, you have pleural pressure is 0, pleural pressure directly measured with wafers, with the probes. Okay, is the real pressure in the pleura. Is 0, and the esophageal pressure is 6. Okay? And it's the same here in the expiration. So first message, the pressure of esophageal pressure does not represent the absolute value at end expiration in the dependent lung, okay? Then we look at in the non-dependent. We look at the dependent. Again, you see here, you have 10 of pleural pressure and you have 6 in esophageal pressure. Much more in the esophageal pressure than the real regional pressure. 4 or 5 centimeters of water. What we are talking about. On average, in the middle, yes, more or less in the middle, the pleural pressure in the middle, because the esophageal catheter, you remember the CT scan, is exactly in the middle of the chest, represents more or less the regional pleural pressure. In the middle, but we have a regional distribution. And this is why the vertical gradient of the pressure here is equivalent to the gradient of the superimposed pressure. So higher is the weight of the lung due to the edema, higher is the increase in the gradient in the pleural pressure. So this is an additional variable that you have. But what we are measuring by esophageal pressure is the pressure more or less in the middle of the lung. Now there are new data in 3 cadavers, so very limited. And you see again, this is the expiratory transpulmonary pressure, directly measured, and the PEEP level. And you see that again, they also found that in non-dependent, compared to the dependent, you see that the transpulmonary pressure is negative, so pleural pressure is positive, here, and there is, in the middle, the esophageal represent, again, is the middle, even in the cadavers. So exactly our data reproduced. But you see how much difference between non-dependent and the dependent regions. We are talking about 5-6 centimeters of water difference in terms of absolute. When they look at the inspiratory transpulmonary, it was exactly the same. So you see here the non-dependent sensor, much higher transpulmonary as compared to the dependent sensor. So means that, again, in inspiration, there are not correlation between the esophageal pressure and the real regional pressure. There are two methods, different methods to measure. The one is proposed by Talmor, which is the absolute difference. For example, here you have transpulmonary pressure at end inspiration is 3, transpulmonary pressure at end expiration is 6. Or here they added PEEP and you have 12 at end inspiration and 4 at end expiration. This is very easy. So you measure the airway pressure, you measure the esophageal pressure, and you make the difference between the airway pressure and the esophageal pressure. So you assume that the esophageal pressure is the equivalent of the pleural pressure. But I showed you that this is not the truth. This is just the average pressure, but not the regional one. Then there are two other methods. One is the elastance-derived measurement. How it is? This is a control mechanical ventilation, you see, and this is esophagus. You go from plateau pressure of 22 and PEEP of 6. This is an example. Driving pressure of 16, tidal volume 600. And this is the esophageal pressure at end inspiration and then expiration, 20 and 17. Difference 3, okay? Now, if we measure the absolute difference is 22 minus 20. So means plus 2. Do you agree? Talmor would measure like this, okay? At end expiration is 6 minus 17 is minus 11, okay? Means that you have, at this point, Talmor would put 15 of PEEP to counterbalance this negative transpulmonary pressure. Means that the esophageal pressure is higher than the pressure in the lung. And this should cause the collapse, okay? Now, one hypothesis is to estimate the pressure as a plateau pressure, or PEEP, times the elastance of the lung divided the total elastance. This is in order to estimate a possible transpulmonary pressure corrected for the individual patient. If you do like this, you have, I made the calculation, so the elastance of the lung is 26, of the respiratory system is 32, so the ratio is 0.8. So you have 22 times 0.8 means that with the elastance derived, the transpulmonary pressure at end inspiration should be 17.6, which is completely different from the transpulmonary pressure measured by the absolute numbers. And if you look at the PEEP at the expiration, is the same. You have 6, so the PEEP 6 times 0.8 is 5, which is completely different from minus 11. Is it clear? So if you measure by the elastance derived, you have other numbers compared to the absolute. And we don't like this method. We like the released derived method. It's another method proposed. Here you have the occlusion at end inspiration at PEEP, and then you have to go to ZIP. So you standardize for the change in pressure from a PEEP level to ZIP. And this is the numbers for the esophageal pressure. So again, absolute difference here is 30 minus 12. So the transpulmonary pressure here is plus 18. Do you agree? At end expiration is 10 minus 9, so is 1. Okay? Now, how is calculated the release derived method? It's calculated like 30 minus ZIP minus 12 minus 16. So the major change in transpulmonary pressure. So this means that you have around 24 centimeters of water. That compared to 18 is very different. If you look at PEEP, is 10 minus 0 minus 9 minus 6. So means 7 centimeters of water, which is completely different from 1. So even for the release method, there is no correlation. So whatever you do, you have different numbers. I don't like that. And in fact, if you compare the elastance derived with the Talmor absolute, and this is the best PEEP according to the end expiration. I showed you that is the case for inspiration and expiration, whatever you want. You see that there is no correlation. You can put the PEEP by random, or better, you put the PEEP on PO2 FO2 table, believe me, it's much better. So no correlation. And then Cumello here, they compare the elastance and the release method. And you see that the difference in terms of, this was transpulmonary pressure, is around plus minus 2 centimeters of water at low PEEP, and at P15 plus minus 4 centimeters of water. So it's higher the error that you have by this measurement than to set PEEP with whatever other measurement system, in my opinion. So then we have other problems. If you have a chest tube, what should we do? The nasogastric tube we discussed. The effect of pleural effusion is another issue. When you have one lung injury, and prone position was discussed today. I measured esophageal pressure in supine and prone, but we have a problem, because when we turn the patient prone, this effect is completely reversed. So even the absolute numbers are completely without any relationship with what you are doing. We found that those patients who decreased the chest wall compliance have better oxygenation in prone. And we say, wow, yes, because there were changes in regional compliance. Probably it was not like that, but this I was thinking after, year after. Because when you are in supine position, you have the effect of the mediastinum. When you are prone, you have less effect on mediastinum. So those patients that likely recruited, they are more ventilated, so they have more exchange in pleural pressure because you are ventilated. And so we found that like a reduction in chest wall compliance. But probably it was not a reduction in chest wall compliance. My study should be reinterpreted. My study in 2000 is very much quoted, but probably people that did not, I even did not believe at that time. I did not understand at the time. Probably it was just because those patients recruited and they improved oxygenation, not because the chest wall changed. Because there were more aeration here, and so you have more swing in the esophageal pressure, which is nothing to do with chest wall compliance. So many difficulties. The dark side, you see here, many sources of error, many problems related to the absolute values. And then we have also some contraindication, but these are the regional variation. So we can skip these slides. This is just to give you some advice. This is the chest wall elastance, and this is the intra-abdominal pressure. You see the chest wall elastance usually is higher when intra-abdominal pressure is higher than 20 millimeters. One suggestion that we proposed to correct the pressure for the intra-abdominal pressure is the following. You have pressure, PEEP or inspiratory pressure. Pressure target, intra-abdominal pressure, minus 13. Why minus 13 in centimeters of water? Because it's the average pressure on mechanically ventilated patients. Divided to Y2, because half of the pressure in the abdomen is transferred in the pleura. So if you have a target of 27, for example, of plateau pressure, you have an intra-abdominal pressure of 21, you can correct this measure very easily. 21 minus 13 divided 2. So means 27 plus 8 divided 2, so means 27 plus 4, 31. So it means that if you have an intra-abdominal pressure of 21 centimeters of water, or equivalent of 15 millimeters of mercury, you should correct, if you want to get the same level of transpulmonary pressure, for 5 centimeters of water higher in airway pressure. Is it clear? In an obese patient, you can accept for the same level of safety 4 to 5 centimeters of water higher in the airway pressure without measuring any any esophageal pressure. Just very easy bedside correction. Spontaneous breathing, just two slides. You see here, this is pressure support. This is the esophageal pressure. This is true. In spontaneous breathing, the transpulmonary pressure, you don't see the transpulmonary pressure during the airway pressure because you don't see this negative part. So if the effort is too high, if you don't measure esophageal pressure, you don't have any information about the effort of the patient. I could say, yes, you measure the PO1. If the PO1 is higher than 3 or 4, means that the inspiratory effort is too high, and you should correct for that. I like very much PO1. We should go back to the PO1. And again, this is from Amato. You see here is the pleural pressure in the non-dependent. This is in the dependent, and this is the esophageal pressure. Look at that. In the dependent region, -10 of swing. Esophageal pressure, -3, -4. And in the upper, -4. So even when you measure during assisted ventilation, you see here, you underestimate with esophageal pressure what's happening in the more caudal areas of the pleura. Okay, just few cases in patients. Why we should not rely too much in this. This is in obese patients. American group from Boston. And they look at the obese patients, and you see what they found, that in order to achieve a transpulmonary pressure at end expiration, positive, in order to avoid atelectasis, in obese patients undergoing surgery, PEEP need to be applied, PEEP of 20, to have a transpulmonary pressure positive. But I show you that we are talking about lottery numbers. And in fact, when we reproduced the same in obese patients, and we look at the PEEP by using the AT, so what really happens in the lung, you see that we found some dispersion in the best PEEP by AT in obese patients, but around 12 centimeters of water, not 20. So it means that to set PEEP according to the transpulmonary pressure gives you, I don't know if numbers, that setting of PEEP without any sense. If you compare with the AT, which at least you visualize what you going on to the lung. And then these are the data in patients with surgery. I suggest you, if you have not opportunity, look at JAMA, published on June 3, the largest study ever done. I think also Iran is here. We were at the ESA, we showed this data in the PROBASE trial, more than 2,000 patients randomized, higher PEEP, 12 versus 4 of PEEP. It's also combined with the PROVILO trial, another trial from our team, 900 patients, non-obese patients. No difference in outcome, no difference of outcome, but more hypotension, more bradycardia, more vasoactive drug, with a little bit higher need of rescue desaturation, but just increasing the FiO2. So it means that why to apply 20 of PEEP according to the transpulmonary pressure? If just with 12, you have a much more negative hemodynamic effects, and to correct the desaturation is just enough to increase the FiO2 from 0.5 to 0.6. So don't use a high PEEP in obese patient during surgery. Just increase the FiO2. If you, just in a very few patients, you have to increase PEEP higher than 5. And if you have more details, you can have a look at the paper. So by using this, without any transpulmonary pressure, just by using the logic, 1 of 2 5 patients with hypertension, 1 on 10 without vasoactive drug, 1 on 10 need increase, a little bit increase of 10% FiO2. So on 320 million operation in Europe, we can save more, almost 100 million patients without vasoactive drugs and hypotension by using our technique. And in obese patients from IFSO 2018, we can save almost every year 120,000 patients without hypotension due to the PEEP and vasoactive drugs. This, I think, why randomized trials are also important. Okay, just last 2 minutes on RDS. In operating room, in non-thoracic surgery, non-cardiovascular surgery, ProVilo trial, ProBase trial, the 2 largest trial, no PEEP higher than 5. Tidal volume, 7 minutes per predicted body weight, no recruitment maneuver. This is the rules, very simple rules from provenant investigators, from randomized trials. Now we look at the RDS. This is a very nice study from Cumello. They said the people with different methods. This is the PO2 FO2 table. And you see that you have higher PEEP, higher but not higher than 15, in more recruitable patients, and less PEEP in less recruitable. I like that. Oxygenation. But look at this. If you look at the best driving pressure, you have exactly the same. You have the opposite effects. Higher PEEP in less recruitable, lower PEEP in more recruitable. So don't set the PEEP according to the best driving pressure. The driving pressure is only useful to optimize the tidal volume, not the PEEP. You have the opposite effects. If you the stress index the same, if you use the esophageal pressure has no real value. So in fact, you can do whatever you want. Okay, it's even worse than this. At least here you know that you are worse. Here you don't know because it's a lottery number. So this is my suggestion, again, that will be discussed later. Minimal PEEP for minimal oxygenation, the best way to set PEEP. Not transpiratory pressure, not driving pressure. This is the study that was commented before. I think that the major issue here is that they compared with the higher PEEP group of NIH table. I would have compared with the lower PEEP. But if you remember the NIH trial, you can compare high versus low, no difference, so I would expect no difference. So the consequence, don't use esophageal pressure. Too complicated. Use the low PEEP FO2 table. So close the lung. This will be discussed later very easily. Just gently ventilate the aerated lung and keep the atelectasis at rest with minimal tidal volume and minimal driving pressure and minimal PEEP for minimal oxygenation. So the conclusion are the respiratory mechanics and perhaps lung mechanics, but I show you that it's very difficult to partition and to interpret data. May help to optimize mechanical ventilation, tidal volume, plateau pressure, driving pressure, PEEP and respiratory. And respiratory is the key at the moment. Mechanical power may be a potential new parameter to optimize ventilator setting from operating room to RDS. I gave you some threshold. Of course, this is not randomized trial, but interesting data. Esophageal and transpiratory pressure are very advanced monitoring with many potential applications, but I show you that we need much better knowledge in terms of technology and interpretation of data. I just show you clear example that whatever you measure, you can get different data. So how can you set mechanical ventilation in something that is not reliable at the moment? Of course, we need more evidence for mechanical power and esophageal pressure and transpiratory pressure to optimize mechanical ventilation before any clinical application of these techniques at the bedside. Thank you so much.
Thank you very much. I mean, it was an exceptional lecture. I think 2 major areas, mechanical power and transpulmonary pressure. So I think any questions, shall we start discussing the talk? Yes.
Hello there. Thank you so much. I just wondered, the animal models from your group, were they lung injury models, all of them?
Yes,
they
yes,
weren't normal lungs?
yes. Our model was lung injury
lung injury.
with oleic acid. And they reproduced more or less the same in the study by Amato in controlled mechanical ventilation. We know now that the esophageal pressure does not represent the dependent lung region. So how can you set the PEEP, for example, on that? We know that it's more likely in controlled mechanical ventilation, even in lung injury, with the average level of pressure. Okay, we can accept that, but it's not the dependent. So it's nothing to do with the atelectasis.
Sure. My only other
So what I think is that if there is some possible application is the difference between inspiration and expiration, so the delta. But so what?
Sorry, my only other question was about a subgroup of patients, which are the spinal injured patients, who generally the approach is, again, anecdotal, not evidence-based, it's retrospective data, but the approach is large volume ventilation to reduce atelectasis and encourage. So my only question was your comment on that approach.
So spine, we're talking about spinal? Spinal. So, or whatever, also neuro patients, other. I mean, we did not discuss in this event, symposium, the non-RDS patients. What we know now, we published just in October the PREVENT trial on JAMA, 1,000 patients. We compared 10, and it was not more than 10 because, of course, we have to follow the rules. We try not, but within the limits, and compare with 6. What we found was that in non-RDS patients, you can start with low tidal volume, but if you can allow assisted ventilation with less sedation, up to 10 milliliters per kilogram, there was no effect in terms of outcome, but there was less acidosis, less hypercapnia, and even less ventilator-free days in those groups who were intubated in intensive care. So probably in non-RDS patients, if we can allow more spontaneous breathing, we have to follow the patient and allow a little bit higher tidal volume. And curiously, in our study, we had some patients that no RDS because they were hypoxemic, so PO2 was less than 200, were 20% of the patients on 2,000, but was not formally RDS because there were no bilateral injury. Even in those patients, but was not powered for that, there was positive effects of higher tidal volume within that limit. But these are non-RDS. So I think that in this patient, we can likely to allow a little bit higher tidal volume. But what about PEEP? We have some meta-analysis that we did, 9, 8 versus less than 5, no difference. But we have RELAX trial, I was discussing with Luigi, is just to be completed, I think, for the end of the year, 1,000 almost patients randomized, non-RDS, 8 of PEEP versus less than 5 as a prophylactic, and we will see the results. And I think we can give the final answer on how to ventilate non-RDS. So coming to your question, in this patient, I would be, if needed, a little bit higher tidal volume, up to 10, and not exceeding 20 of plateau pressure, and PEEP of 5, maximum 7. But not use too much PEEP in these patients, and I would use recruitment only as a rescue if you need.
Thank you very much. Any other questions, Jonathan?
The subject of transpulmonary pressure seems intuitively an appropriate thing to look at. How do you think we can do meaningful studies, at least currently, international studies, over 1,000 patients, when you've eloquently shown what a load of rubbish transpulmonary pressure is?
Yes, that's my point. that I think that actually I would not suggest, if my conclusion here, of course other people can have different ideas, I know that there is some people, I can tell you that probably I was one of the first to measure esophageal pressure with very, very tricky methods in the 94. So I was in favor. I am also, I measure, if you look in 95, we published the first paper on RDS patients, the partitioning, so I love that. And I think I'm one of the few who measured transpulmonary pressure in obese patients during anesthesia, laparoscopy, and so on. So it's talking a person that started to measure the transpulmonary pressure in the 94, okay, with Bicor and so on. But now, from what we know, I think that we have to understand much more and to standardize much more what we are measuring, because as I show you, whatever you measure, you can get different numbers. So it's impossible to me, actually, if you think to plan a study on that, you can test on end expiration, bow, end inspiration, bow, driving pressure, you don't know. So, or at least to decide something, but I think that if we plan now a study, a big study, the probability to have a chance to get a positive results is almost equivalent to 0. And my fear is that if we use this technique, because now in more severe patients, we have to use this. Why? The risk to me is that you increase, we don't know how to set the PEEP by airway pressure. But I think that with esophageal pressure, as I tried to demonstrate to you today, we can even more error than the conventional. This does not mean that for research purposes, to understand better a little bit or what's going on, this may be a technique that may be applied. But I would reserve actually this technique only for research and very specific physiological study. This is my conclusion today. Of course, other people may be in contrast, like people that they like higher PEEP in anesthesia. We have the data, we like the randomized trial, big data, and I think that the data make the difference.